I'm going to give you the sort of general view of how we've run ImROC. But there's a sort of logic, I think, going throughout ImROC in a way, and that's the fact that we started, many people have thought about recovery. It's got a large literature, not a lot in the, if you like, the English literature, not in the American literature. Before we wrote our short piece on it, I think there was only really Julie and Rachel Perkins' book on it, wasn't there, Julie, at that time, of an English nature. And Glenn, I guess, yeah, and then Mike Slade's stuff. So just to remind you, really, what we were concerned about is this notion of personal recovery, in a sense, living a life beyond illness. And we took, as many people do, Bill Anthony's definition as a sort of good starting point. And really sort of made a distinction between that and the usual notion of clinical recovery. There's some sort of overlap between it, clinical recovery being a sort of sense of recovering in terms of your symptoms as a notion of cure. It's a traditional, if you like, notions of recovery. But also, of course, the fact that recovery is a process. People talk about a journey or in recovery. And it's also, in its sort of roots, it could be called a civil rights movement. It's about people with mental health problems asking not only for better services, but a better position in society, like a sort of social justice notion. And of course, if you're looking, many of the ideas of recovery come from people who use services, people with lived experience of mental health problems. And if you look at their stories, their narratives, you'll find there's always consistently sort of three general themes going through them to what is beneficial for recovery: hope, agency, or sometimes control, and opportunity. And the latest sort of literature search on that is Mike Slade's group, and they came up with the Chime framework, which is entirely consistent with what a lot of other people have come up with before, which is again consistent with the notion of hope, agency, and opportunity. And in a way, those things are useful to know about because they help guide they can help guide your thinking when you're thinking about what is a recovery oriented, but what's it trying to achieve. And maybe also it's useful, it's helped us think about how might we measure outcomes from a recovery point of view. And of course, what we came across was the idea that it was rapidly becoming a sort of new treatment in a way. But of course, recovery isn't a new treatment. I as a clinician don't make people recover. That's to do with their own personal journeys. But of course, services, professionals, people they meet can influence those recovery journeys. And that's an important thing, I think, to think about, because we often influence those journeys unhelpfully. The idea would be to facilitate those journeys, to influence them in a sort of helpful way. And so what we're interested in, perhaps as people working in mental health services, is our practice, can our services be more recovery oriented? And of course, what we found was it's been around in UK policy for really over 10 years now. And it's certainly a key part of and a strategic aim in the current government's mental health policy, no health without mental health. But what I noticed in a few years ago, you'd go around and you'd say, well, look, it's central to policy. What are you doing? Are you doing something in this area? And people say, yeah, we're doing recovery now. But there's a sort of lack of logic in that. There's people working in services have said we don't do recovery. So what are you doing? Well, we've got recovery teams. Good. What are they doing? Well, nothing different from what the teams used to do before. And of course, in a way, what we didn't have, we had it in policy, but we had no way of thinking what a recovery-orientated practice and service might actually look like. And the logic of part of developing the ImROC project was to look at those very things. And all we did, we realised there were, when we set this up, I think it was 2008 when we started this work, we realised that out there were elements of good practice in some trusts, but it wasn't widespread, and it was, there were pockets of good practice. So what we did, we recruited 5 trusts, mainly in the southeast, mainly the south, who we knew had made some sort of inroads into this, and we did a series of workshops. In preparation for that, we wrote this Making Recovery a Reality. I wrote that with Jeff Shepherd and Mike Slade. We got a group of people together who thought knew about this subject as a sort of steering group. We did the workshops. At the workshops, we had a complete mixed bunch of people: service users, carers, clinicians, managers, commissioners, social service people, and so on. And out of that, and with a view, an eye on the literature, we found these 10 key challenges, which formed the basis of what became the ImROC project. But essentially what we're doing in those 10 key challenges is looking at changing practice, changing the way services are delivered, and some of the elements of those services, and importantly, wanting to change the culture in which that practice and services goes on. And so we were not only interested in changing the day-to-day interactions between clinicians and service users, but the whole staff working within an organisation. We wanted to look at developing comprehensive user-led education and training programs, and as part of that to start developing some sort of recovery education unit within each trust, and that's developed as the idea of recovery colleges. We also wanted to get a sort of organisational commitment. We thought organisations need to create the culture. Within that, there was an increase in personalisation and choice, but also, importantly, we thought transforming the workforce was a key element of this. And transforming the workforce for us predominantly meant increasing the number of people with lived experiences working as peer workers within that organisation. The emphasis here was on paid work within it. They were employed like anybody else. Service user involvement was going to be key to all this, as was actually leadership from the top as well. But of course, staff need supporting their own recovery journeys. This, not just because, of course, this idea of recovery may be well alien to them and challenging, but also because there's a sufficient number of people within the workforce who have their own recovery journeys. They experience mental health problems themselves, or if they're not, then we've all got something significant to offer in that area. And finally, I think we felt that organisations should be more outward-looking. Building relationships with local organisations that weren't necessarily mental health orientated, but were important for people in their recovery or outside mental health services. So I'm thinking here education, leisure, employment services. That's why I put IPS there, because it's one of the few, I think, really key sort of evidence-based services.